So it is my very great pleasure to introduce Harry Büller, who is a great friend of the Society and one of the real giants of the field of thrombosis and anticoagulant research. And he continues to be hugely active now in the field of developing the factor 11 inhibitors, about which he is going to speak to us. Harry.
Good morning. Thanks very much, AJ. Very nice to see you and all the other colleagues. I missed two things. That's the company in the nice setting as always, and the jacarandas. However, I know that Barry is very strict, so I'm going to stick to the 10 minutes about the factor 11. Now, probably most of you have heard me talking about this earlier and promised that it was around the corner, but really, as always, I'm pathologically optimistic. The factor 11 and maybe the factor 12 is really around the corner. These are my disclosures. And the reason to start here is actually, if you look at this nice figure, look what is happening to the left side, the contact activation with what was already mentioned, the NETs, the poly-Ps and many others. I'll list them in my next slide. And really what we have started to see is that this element of the calculation system is very well organized. And this is the slide I referred to. This is what we now have learned over the last couple of years. What are the activators of the intrinsic pathway in vivo? As you can see, the polyphosphate, the nucleic acid, but if you go down that list, quite a number of compounds that are present in disease really can start that. Classically, we looked at silica and kaolin in our test, but the bottom line actually is that in normal physiology or pathophysiology, actually the number of agents that can start that process is numerous. And if you then look at what happens in terms of the inhibitors, now this is a very nice overview for those who are interested, is that you can see on the left is the antisense for factor 11. I'll touch on that one as well. But there are monoclonal antibodies, small molecules targeted at in the top in the middle at factor 11 or factor 11A, and then to the right factor 12. And basically what you see here, there's even antisense for factor 12 available for evaluation. Now, this is the study that starts in 2015, and my predictions at that time would be that we would see a tsunami in a very short period of time with many different factor 11 agents or agents to stop factor 11. The truth, though, is that it has taken some time, as I said, about 5 years. But and I'll finish with that slide, where all that activity is. This is the antisense, and for those of you who are not familiar with it, it basically blocks the synthesis of factor 11. Now, factor 11 has a half-life that really requires the initiation of treatment some weeks before you actually get down to levels that are appreciable. In this study, which was published in 2015, we compared in the classical model of knee surgery, enoxaparin, 40 milligrams, as you can see, 72 patients, and then a dose of 200 milligram antisense and 300 with the numbers there. The rest of this slide basically is to illustrate that these groups were comparable. And the question, of course, which is real, is why always in these patients with knee surgery? And the answer is very simple. That still is an intervention in which if you don't do anything, the rate of thrombosis detected by venography is about 50 to 60%. With enoxaparin, that is in the order of about 30%. So the question here was, how does these antisense strategies compare to the standard? And here, this little figure is to illustrate that with the high dose, the 300 milligram, the green line, what you basically see here is that at the time of surgery, the factor 11 concentration is about 20 or even lower, 20% of normal. While, as you see with enoxaparin, there's a dilution effect, but it basically is untouched. Now, this is important to realize. So at the time of surgery, these patients actually had very low or even undetectable levels of factor 11. And here are these findings. Again, they are old, but it's just for comparison. Is what you can see here, the enoxaparin, 30%. This is mainly venography detected deep vein thrombosis. And with the ISIS 200 is non-inferior to the enoxaparin. But this rate of 4% with the high dose at 300 milligram is really unparalleled. It's not been seen with any of the other agents that we have available. And I'd like you to keep that 4% in mind, because the real point here is that these rates were low, but also if you actually looked at the clots, they were very, very small indeed. And this came with no increased risk of bleeding. Here is the combination clinically relevant bleeding, major and clinically relevant, non-major bleeding, which occurred in 8%, in most studies about 6% with enoxaparin, but clearly even with the 300 milligram, no indication that these very effective doses were associated with an increase of post-operative bleeding. Again, I remind you the fact that this was a factor 11 concentrations during and of course in the post-operative period. This particular compound went on to be then investigated in patients with end-stage renal disease. And here it basically makes the point that this is not a rare disease. There are about 2 million individuals on a global level that actually need to undergo these dialysis on a weekly basis. Now, next to that, they have a very high risk of stroke and cardiovascular events. This slide, I hope it shows better with you than it does with me, but the bottom line here is that category 3 and 4, you have two things. One is the air trap and one is the dialysis, for those of you not familiar. But what happens here is clot formation in category D and a coagulated system in category 4. And the question therefore was, if you add factor 11 inhibition, what happens to these thrombosis substitute endpoints? Now, in the air trap, as you can see here, that compared to placebo, there really is a quite a significant reduction, both with the 200 and the 300 milligram in these clotting events in the air trap, and a very similar picture is seen in the dialyser clotting measurement. So this is with the factor 11 Ionis. Then we had the opportunity to look at the Foxtrot trial. The Foxtrot trial, as you can see here, was a monoclonal antibody, osisimab, compared with the enoxaparin in a very similar setting. And the interesting thing here is there were two controls, apixaban and actually enoxaparin. And I'd like to draw your attention here to the top line, the apixaban, the rate of thrombosis. So this needs to be compared to what I showed you earlier in the antisense trial. Apixaban is a 14.5%, with enoxaparin is 26%. But if you look at either the post-operative or the pre-operative starter doses, look at the primary efficacy outcome, they never get lower than actually in the post-operative highest dose, 11%. So non-inferior, if you want, to apixaban. Not, though, at the level of 3 to 4%. In terms of safety, there was a little mixed signal here. If you look at that highest dose that I just showed you, the 1.8 post-operative, there was a suggestion of a higher bleeding rate. Mind you, very low numbers, but the 4.7%, of course, therefore, was some kind of a little concern. Now, if I go back to the efficacy table here, looking at the post-operative start, it really is around 15, 16, 17% if you want, with the post-operative start of this particular antibody. And if you then look at the bleeding with those doses, 1% and 3%. The conclusion, therefore, is yes, this antibody is effective. It doesn't reach those levels that were seen with the antisense. To conclude, here is an overview of the studies that are ongoing. I shared with you the antisense in ESRD. This is the ocizumab. I'd like to draw your attention to this particular, the antibody of Antos 005 that is about to be completed, which I think is one of the most promising one, works immediately. But more importantly, it goes back to my first remark, that this will be then subsequently taken into clinical trials in patients with cancer-associated venous thrombosis. There are similar designs for catheter-associated thrombosis. So in conclusion, Mr. Chairman, Factor XI is emerging as a promising target for new anticoagulants. Several strategies to inhibit are under investigation. And I think the take-home message is this is not a single family. You really have to look at what the particular drug is doing. There are ongoing trials with Factor XI. And Factor XII, I think, particularly also the antisense, is coming to clinical fruition very quickly. Thank you for your attention.
Harry, thank you very much indeed for your marvelous and clear presentation. Can I ask you, you make the point that there is clearly a difference in terms of these different agents emerging. How would you rate in your own sense at the moment the distinction between Factor XI and Factor XII? Is it going to be the next big debate, Factor II versus Factor X, that we had many years ago? Number one. And number two, within the Factor XIs, what emphasis do you put on inhibitors, antibodies that are able to neutralize activated Factor XI as well as Factor XI versus, for instance, the use of an antisense that can eradicate synthesis of Factor XI?
Yeah, those are two excellent questions, AJ. The battle of Factor XII and Factor XI, yes, will occur. I think if you look at the totality of evidence right now, inhibiting Factor XI in a thrombotic setting, so venous and arterial thrombosis is probably the winner. Although with Factor XII, I think in some of the extrinsic activations, like in catheters and in devices like renal diseases, etc., is promising. But your second question is very important indeed. These, whether it's an antisense, whether it's an antibody, whether it's a small molecule, they really do act different, and they have to deliver the evidence that it makes a difference. Now, the MAA, that's the antibody that I talked about, the Antos, that inhibits both zymogen, Factor XI, and 11A. And if that turns out to be very effective, it tells you the message that just simply inhibiting the active Factor XI may not be sufficient. If you take the Foxtrot data, I would take that as a hypothesis that the rates that we've seen with antisense, which is knocking out the complete protein, and an antibody that knocks out both the zymogen and the active, I think that's where the battle is going to be. So an antibody is not the same as another antibody. Small molecules are coming into play very soon, is even more complicated. So yes, one lesson to take home is it really depends on the mechanism of action of inhibition of Factor XI, which is going to determine the clinical efficacy.
Thank you, Harry. Are there any other questions?
Can I ask, Harry, do you think then that with the lack of bleeding, that this might be a good target at the moment to be trying out on the COVID patients, given the fact that it is working on contact activation and that the bleeding risk looks to be quite low? Do you think maybe we should be targeting it?
No, I think that's an excellent point, Barry, and that is that, of course, the intrinsic activation in COVID is going to be a focus, and some of your slides already illustrated that. There is massive intrinsic pathway activation in COVID, and so therefore the theoretical reasons to use these agents in that setting are very, very attractive, and I think need to be pioneered by people that are going to try it's off-label and you have all the other problems. But in these cytokine storms, together with massive coagulation activation, even a combination of low molecular weight heparin and 11 inhibition is very attractive.
Thank you, Harry.
I can't see any other questions. Maybe if we have a couple of minutes, I can ask you one further question, Harry. In terms of the small peptide oral inhibitors, what is their mechanism of action? Is it principally to neutralize the active site or to inhibit the zymogen?
Yeah, you're right, AJ. The principal one is to inhibit the active site. Now, one thing with the oral agents or with the small molecule is we really need to be good at predicting their concentrations over time. And what we've seen in the antisense study with the 200 milligram, which was just a little less reduction in factor 11, we actually had levels comparable to enoxaparin, which tells me the story that what happened with antisense is it's a complete inhibition. If you have a very strong antibody that inhibits the zymogen that is constant over time, actually works for weeks, the big challenge with these oral small molecules will be to be in the therapeutic range constantly, because as you can imagine, that when it drops off, you actually may have a kind of a rebound phenomenon. So all those challenges are definitely there. I agree that the small molecules are attractive, oral, etc. But whether it bears out in clinical efficacy is something we really need to carefully watch.